I would like to start by telling you something about my mother, who had dementia, and the care and support she received before she died in 2017. It's a story from the global north, from the Netherlands, but at the same time a story of any one of us sadly losing a parent or partner to dementia. It will illustrate some of the issues that I will discuss in this lecture. These are my parents enjoying the sun a few months before they died. My mother with moderately severe dementia, my father with severe physical and cognitive impairment after a stroke. Here they are sitting outside on the terrace of a care farm. I will share the story of what happened before they moved to this farm. My mother increasingly showed symptoms of dementia. She was afraid of getting dementia because my grandparents, aunts and uncles had almost all suffered from it. My mother didn't want to talk about it, though she knew I had been working in the field for dementia for many years. It took a great effort for me to convince her to go to an Alzheimer's center, a center when they do all the diagnostics in one day, and by the end of the day you receive the results. The neurologist told her she had amyloid angiopathy. However, that the disease will lead to dementia, that was something he didn't tell. She went home happy, although at times quite anxious. It became increasingly difficult for her to continue her life in her own way, a way that was important for her. Fortunately, my father supported her and provided support as needed. He reminded her when she forgot. He showed her the way when she lost it. He helped her to express herself when she couldn't find the right words. But then he had a major stroke and was sent to a nursing home for rehabilitation. My mother stayed at home alone, losing the structure my father provided, and her dementia rapidly increased. All of the children, including myself, had jobs. They had busy lives and lived 1 to 2 hours driving distance away. Of course, we as children tried to do whatever we could to enable my mother to continue her life alone at home, a life that she loved. Together with her, we did the shopping, we took her to my dad, and we provided company and emotional support. However, she started to go outside during the night to search for my father and was increasingly confused when we were not around. We called in the help of a so-called case manager. This is often a nurse in the Netherlands who specializes in the field of dementia, a professional who is very important, especially with a complex care system such as the Dutch care system. The case manager helped to organize and coordinate the home care that was needed. For example, care staff who visited her before sleeping. She supported us as family. After some time, my parents moved together to a care home, not the care farm where they are enjoying the sun on this picture. They received care in the care home, but the provision of professional care is one thing. Enabling the person to continue their life in a way that is meaningful for them is another thing. In this home, the care staff were not trained in providing care to people with dementia. Providing care to people with dementia is a complex job for which you need training and recognition. The care staff didn't encourage my mother to go outside to have physical exercise. Also, they didn't stop her eating, and as a result, she gained weight, developed depressive symptoms, and over time her well-being decreased. My sister in particular, who lived around the corner, had almost a daily task of helping my parents, not only with activities as going to the hairdresser or the dentist, but also with comforting them when they were upset, and the care staff had no clue what to do. In the end, after discussion with my parents, they moved to the care farm, a care home with a small lake and animals with a lot of space for the residents with dementia to go outside and breathe fresh air. There, they received the care that they needed. There, they both died in 2017. My parents had a costly journey that didn't always meet their needs, nor reduced the burden of us children, the family carers. Why am I sharing this personal story with you? Firstly, because worldwide, in the global south and the global north, we face the same challenge: to develop a sustainable and equitable system for the provision of long-term care. A system for the provision of appropriate and good quality care, and that meet the needs of people with dementia and their carers. And a second reason to share my personal story is that I come from the global north. So my background and descent make me a colonist fair and square. So the last thing I would like to pretend is that I know the answers for the global south. Since care and support are so closely interwoven with the local settings in and within a country. At the same time, we share the responsibility to care for people with dementia and others in need of long-term care. Therefore, I would like to discuss a selection of issues associated with the long-term care for people with dementia that, in my view, require further reflection and research in the global north and the global south. And this selection is based on my experience as a researcher, teacher, and clinician in the Netherlands, and as a diplomat at the World Health Organization leading the work on long-term care. And in my lecture, I will make the case for the development of long-term care researchers with training in different disciplines. The first issue in the field of long-term care and dementia that I would like to discuss is ageism and stigma. To illustrate the extent to which stigma is steeped in our societies, I will share some of the results of a report that was published by Alzheimer's Disease International 2 months ago. The report describes the results of a global study on attitudes to dementia. The original English questionnaire was translated in 32 languages, and over 60,000 people from all regions worldwide answered some or all of the questions. More than 2/3 of the respondents think that dementia is caused by aging. But what is even more worrisome is that 62% of the healthcare professionals think that dementia is a common part of aging. Next slide, please. In addition, a substantial proportion of the respondents think that dementia is a result of external forces such as bad luck, God's will, or even witchcraft. And from research also carried out in South Africa, we know what the consequences can be when people, mostly older women, are perceived as witches. They are mistreated or even killed. Let's be clear, dementia is caused by a range of diseases that are mostly progressive, affecting memory, other aspects of cognitive functioning and behavior, and that interfere significantly with a person's ability to carry out daily activities. Alzheimer's disease, the most common cause of dementia, is underlying roughly 60 to 70% of all cases worldwide. But there are also other diseases that can cause dementia, like dementia with Lewy bodies, vascular dementia, a group of diseases that contribute to frontotemporal dementia, alcohol-related dementia, or AIDS, HIV-related dementia. Due to the widespread ageism and stigma attached to dementia, not surprisingly, people with dementia often experience being unfairly treated. The ADI survey shows they often report that the symptoms are being joked at. Their rights and responsibilities are taken away unfairly, people do things for them that they can do themselves, and people don't take their opinion seriously because of their dementia. People with dementia also mention that they are unfair treated by health and medical staff and also by their children or family. Unfair treatment is experienced in all regions, but the green bars on this slide show that some of the reported percentages are specifically high in the African region. Despite some of the hopeful announcements at times, the last one a few weeks ago, there have been no breakthroughs in the treatment of dementia over the past 15 years. Until there is a cure for dementia, prevention, care, support are of utmost importance. And although my lecture will not focus on modifiable risk factors or the prevention of dementia, I do want to stress that this is receiving increasingly attention because even small reductions will have an important impact on public health. Therefore, the Lancet Commission recommends being ambitious about prevention. So treating hypertension, improving childhood education, stimulating physical exercise, maintaining social engagement, reducing smoking, and the management of hearing loss, depression, diabetes, and obesity are among these recommendations. In my lecture, however, I will focus on care and support for people who have dementia and their carers, establishing sustainable and equitable long-term care systems for the provision of this care is a challenge in the Global South and the Global North, although for different reasons. I will discuss a selection of challenges related to long-term care that require our attention and research. But let me first explain the WHO healthy aging model and what we mean by long-term care. Often when the question is raised, which care and support is needed for people with dementia, different types of services are mentioned, like support groups or respite care or things like that. However, this is not so helpful because the type of services that are needed will depend on the local situation, which is specific with its specific epidemiological, socio-economic, cultural, religious and political context. Moreover, even when there is a broad spectrum of services available, like in the Netherlands, the quality of care can still be inappropriate. Think of my mother. In the first care home, the staff couldn't deal with her dementia and she needed to move to another home. To understand which type of services are needed, I will present some of the work in which I was involved at WHO in Geneva during 2014 till the end of 2018, seconded by the Dutch Ministry of Health. We developed the Global Strategy and Action Plan on Aging, and that was developed in 2015 and adopted through a resolution in the World Health Assembly by WHO's 194 member states, including the Netherlands and also South Africa. The global strategy is based on the healthy aging model that helps to understand why we need a person-centered approach rather than a service-oriented approach to long-term care. During their life course, on average, people will experience a loss in their mental and physical capacities. And you see that here, it's a line downwards. Of course, there may be differences between people. Some people will have no decline, others will have a decline that starts already earlier, or others have a decline that, which is more an erratic course. But on average, people will show a decline. At a certain point, this decline in mental or physical capacities may result in a significant loss in functioning. Think, for example, of a person who increasingly shows a decline in mobility. At a certain point in time, the person might not be able to walk independently anymore. And as you can see, people's functioning is a bit higher than the capacity, So the blue line is higher than the brown line, and that has to do with, for instance, if you look at me, my vision is not that good. If I don't use my glasses, then I can hardly see you. I see some blurred vision here, and I hardly can interact. But if I put on my glasses, so I have my environment compensating for my vision decline, then I can clearly see you and can interact with you. So that is why this functioning is always a bit higher, because the environment enables you to function at a higher level, even if your capacities are not that high. So at a certain point, this decline in mental or physical capacities may result in a significant loss in functioning. Think, for example, of a person who increasingly shows a decline in mobility. At a certain point, this person might not be able to walk independently anymore. When people experience a significant loss in their capacities, they will need the help of the environment to re-enable them to do what they value in life. For example, a person with a significant loss in mobility might need assistive technology like a walking stick or a wheelchair, a road without potholes and safe crossings, public transport that is wheelchair accessible, and maybe also someone who can push the wheelchair. In this way, the person will be enabled to continue to do their shopping, to visit their friends, or other things that are of value for them. Now think of a person with dementia. There comes a point in time when he or she not only has memory problems, but also a significant loss in functioning. A person with dementia needs the environment to compensate as much as possible for their significant ongoing loss in capacities, to enable them to function on the highest level over time. Therefore, a dementia-friendly environment is so important to enable them to continue to do the things they value, like shopping, cooking, dressing, bathing, meeting friends, and whatsoever. That will have a beneficial impact on a person's well-being over time. The healthy aging model means a paradigm shift from a service-oriented perspective to a person-centered approach. The aim of the care and support we provide is to enable people to do as much as possible themselves. You can have all kinds of services in place and still not do a good job when the services are not focusing on compensating a person's loss in capacities. And think again of my mother. Staff were very polite, but in the end they didn't encourage her to get physical exercise. The goal of care and support is to optimize people's functioning over time, not only the functioning of people who are healthy and have no disease or no chronic condition or whatsoever, but also of people with dementia or other chronic diseases. Optimizing people's functioning over time is what WHO calls long-term care. So, and here you see the definition of the World Health Organization of long-term care, but I'm sure that you will understand it now. The activities undertaken by others to ensure that people with or at a risk of a significant ongoing loss of intrinsic capacity can maintain a level of functional ability consistent with their basic rights, fundamental freedoms, and human dignity. Thus, long-term care should be focused on a person's unique needs. It should focus on the trajectory of functional ability, not only of their functional ability right now, but also over time. And that sounds simpler than it is, as we now know. Long-term care should enable a person to do as much as possible themselves, in line with the principle of self-determination. It should not replace a person's ability or potential ability. This is important to keep in mind when providing health and social care services. Are these services indeed enabling the person with dementia? And we had a lovely discussion before this public lecture. Also looking at some care services that are already here. For example, the hospitalization of people with dementia who don't have an acute care need will not enable them to continue their life with meaning and dignity and to function at the highest level. So you understand, hospitalization of people with dementia is not a good idea. People with dementia are in the first place people and not their disease. Taking over shopping when a person with dementia has difficulty with doing shopping might not be helpful and may lead even to further decline. Instead, we need to analyze people's capacities and try to understand why doing shopping is difficult for the provision of the right support. For example, does the person has problems with making a shopping list or with going to the shopping mall or with paying? These are totally different things. Long-term care should not only be focused on meeting people's basic needs for survival, but also on people's abilities to move around, to build and maintain relationships, to learn, grow and decide, and to contribute to their communities. People still have a life, also when they have dementia. Finally, long-term care can be provided in a range of settings. In a person's own home, in the community, or a hospital or care home, by a range of carers, family, non-family, trained, untrained, paid or unpaid, and financed through different mechanisms. Now, of course, this is highly aspirational. As we all know, there's a huge variation in systems for long-term care worldwide. At one end of the continuum are countries with no or hardly any long-term care system, leaving long-term care entirely or almost entirely to families without any additional support or guidance. In these countries, the challenge is to develop a long-term care system from scratch. At the other end of the continuum, there are some high-income countries like the Netherlands with well-developed systems. The systems provide a variety of services, including community-based and residential care, as well as a free choice of services and providers based on a combination of insurance, tax revenues, and people's own contributions. However, the sustainability of the financing of these long-term care systems is a challenge due to an increasing need, resources that are not always used in an efficient way, and the complexity of the system for the care receiver. And the availability of care services may also increase people's expectations. And last but not least, the continuous focus on person-centered instead of service-oriented care is a challenge and requires constant attention. Now, is there a need for a long-term care system for older people and people with dementia in Africa? The expectation among decision makers is that family and extended family will look after older people and people with dementia in the global south. However, the question can be raised whether older people and people with dementia can actually rely on their family for appropriate care and support in Africa. We will discuss this by zooming in on demographic and epidemiological changes, the role of family norms, and the burden of care for family carers. In the coming decades, an increased proportion of the population in every region will be 65 plus. In Africa, the percentage is still small compared to the rest of the world, and Jacco, you already mentioned it will be still a young continent, but it will grow from 3.4% in 2015 to 5.7% in 2050. Related to this demographic change, the number of people with dementia will also increase. On this slide, you see the different regions and the estimates of the increases in number and the proportionate increases in number. In 2050, the absolute number of people with dementia will be the lowest for the African region, 15.67 million, but the proportionate increase in the number of people with dementia will be the highest for Africa, as you can see, 291%. So this means the number of people with dementia will be almost 4 times higher in 2050 compared to 2015. The estimated number of people with dementia will be only 15% lower than in 2050 than in Europe. So this is a lot. Another demographic change that might alter the availability of family care is the urbanization of the population. Although Africa is mostly rural, with just over 40% of its population living in the urban areas in 2018, the percentage is estimated to increase to 59% in 2050. The percentage of urbanization is relatively high for South Africa compared to other countries of the African region. Young people are migrating from rural areas to the cities to find employment, leaving a relatively older population behind with less access to health services and other infrastructure. Women, the traditional family carers, are increasingly participating in the labor force in several parts of the world, including in sub-Saharan Africa. Consequently, the provision of care will shift to become the responsibility of older people, who might be frail and poor themselves. Moreover, a substantial number of older people don't have family members to provide care for them. In addition to these demographic and epidemiological changes, there are shifts in support patterns in Africa. The drivers of these changes might be different in the Global South compared to the Global North. For example, Abodoren made a case based on a qualitative 3-generational study in Ghana that declines in material family support do not seem to be the result of secularization, which is often thought of, that might have led to a lack of material support for their parents. The middle generation doesn't feel obliged to offer support based on the traditional principle of reciprocal obligation. So they feel that their parents don't deserve it because they have failed to provide them with support, such as education. So that was one of the findings of her study. Finally, the burden of providing care to a relative with dementia might be far-reaching, which also may impair the adequacy of family care. Research carried out in the Global North and the Global South shows that caregivers of people with dementia experience higher levels of psychological distress compared to the general population or non-carers. The ADI survey on stigma shows that family carers for people with dementia in all regions report that the care often has an impact on their health, work, and social life, with a high prevalence rate for all regions, including Europe and Africa, ranging from 47.5% to 69% for all these 3 domains, so not only health, but also work and social life. The general public, healthcare professionals and carers in all regions do often not agree that there is an adequate provision of community services for people with dementia that holds, and the general public is often not willing to have a person with dementia move in with them, with the European and African region showing the lowest willingness, with roughly 1/3 willing to do so. Although this survey is not representative, it does show that family care for people with dementia in the African region may be less self-evident than assumed, which might have serious consequences for the lives of the relatives. Moreover, the burden of providing long-term care is not shared equally and generally falls on female relatives of all ages, particularly in contexts of poverty and vulnerable employment. In these circumstances, the family members who provide long-term care often lack knowledge and resources needed to give adequate care. They also may face a choice between neglecting their work, education, and other economic activities, or neglecting their dependent older family member. One of the pitfalls is to close our eyes to potential care inadequacies in family care, because there are assumptions and questions that at least need scientific research if we are to properly plan for the future of long-term care in Africa and South Africa. Care inadequacies don't just make life hard for the person with dementia, they can also lead to isolation, challenging behaviors, and early death. They can also lead to inappropriately filling acute hospital beds because there is simply nowhere else to go. A long-term care system is needed. Therefore, in the past 3 years, there have been a few meetings in the African region, including Gauteng, led by Jaco Hofman and Isabella Abodoren, and myself on behalf of WHO. In the research policy practice dialogues, we discussed the research agenda to foster long-term care. These dialogues took place with a wide range of stakeholders, including the African Union, HelpAge International, the African Council of Religious Leaders, a wide range of faith-based organizations, the WHO Afro Office, care providers, and researchers. Relevant research questions that were formulated, next slide please. Here you see a picture of our meeting in 2018. Relevant research questions that were formulated include those that address understanding the evolving normative underpinnings of long-term care provision and receipt, such as, and I name a few of these questions to give you a picture, but of course it's not all the questions. So what do people conceive as their family obligations for the provision of long-term care? What are their normative expectations about the responsibilities of the government? What is the type and quality of the family care provided? Relevant questions also include those that address understanding the realities and experiences of care and support provided by families, such as what are the experiences of people with dementia and the family of the adequacy and quality of care received and provided? What is the impact of the care provided on the family of people with dementia? And what are effective ways to support the family to reduce the negative impact of care on their health? And in addition, evidence is needed of the current landscape of long-term care service provision and financing mechanisms. What kind of services are available where, who are the providers, what are the working conditions, whom do they serve and who pays? We must also consider potential platforms for long-term care service expansion. What private sector, faith, community-based or public sector structures or mechanisms exist upon which an expansion of long-term care service provision could be built? And how could they be built upon? So these type of research questions, and like I said, there are many more, form the broad agenda for research to inform decision makers, policy makers, what actions to take to establish sustainable and equitable systems of long-term care. Now, despite potential care inadequacies, a common response for decision makers in developing countries is to claim that there are too many other priorities and that there are no resources available to fill the care gap for older people and people with dementia. The expectation is that families, women, look after their relatives Even though demographic and epidemiological developments might challenge the availability of family care, and the negative impact of providing family care might be high. This challenging situation requires a change in our mindset. Perhaps there are ways we can address the care inadequacies for people with dementia and older people and enhance socio-economic development simultaneously. Perhaps we can frame the situation as an opportunity rather than a dead end. Let me share a study that might help us think differently and illustrate what I mean. In 2017, a report was written by the Women's Budget Group for the International Trade Union Confederation and UN Women. This report provides a theoretical argument for investing in the health and care sector based on an empirical analysis that estimates the impact of investing in social infrastructure and health and care services in particular. The result of the analysis for emerging countries like South Africa show that public investment in the health and care sector, and long-term care in particular, would increase employment. For example, in South Africa, an investment of 2% of the gross domestic product in the health and care sector would lead to a 1.2% rise in employment rate. This analysis shows the potential of thinking in terms of investment and a return on investment rather than in terms of costs. And I really think this is an important aspect. Apart from creating employment for the young, it also has the potential to enable women to join the paid workforce. But the benefit of investing in the health and social sector, health and care sector, will reach beyond economic and employment effects. It will tackle care inadequacies for people who need long-term care, including people with dementia, people with low incomes, and people living in rural areas. The provision of quality health and care services is part of the Sustainable Development Goals, and especially 3.8, and a value in its own right. Now, long-term care systems will necessarily vary according to the cultural setting, capabilities and resources and population need. There is no single system of long-term care that can be applied in every setting, nor even in countries with similar resource constraints. Nevertheless, there are some common goals and strategies for the establishment of long-term care systems that would I like to share. The WHO framework on this slide shows that to establish sustainable and equitable systems of long-term care, government stewardship is needed. This means that governments have the final responsibility for the planning and the resources that are needed. It doesn't mean that governments are responsible for the actual provision of care. Active engagement is required from a broad range of stakeholders, including older people, families, communities, health and social care providers, and other public and private sectors, such as insurance companies, transport, and education. A key role of governments is to steward these partnerships and to build a consensus on and engagement with the system that is most appropriate. And as shown in this framework, sustainable and equitable systems of long-term care under the stewardship of governments need to provide care that is accessible and affordable, upholds rights to protect people's dignity, enhances people's intrinsic capacity, is oriented around the person's needs, and treats the workforce fairly and support unpaid carers. Now, to establish long-term care systems, we propose three interrelated actions. A first action area is the development and continually improvement of the long-term care system infrastructure. This requires a plan and legislation informed by country assessment, including multi-stakeholder consultation and analysis. Sustainable financial mechanisms are needed that provide equitable access to good quality services and resources, supported by a monitoring system to evaluate the progress. Now, a second action area is ensuring the capacity of the workforce, the development of training and support for families and other unpaid carers within communities, and developing training and career opportunities for the paid long-term care workforce. It will also be necessary to ensure an adequate supply and the equitable balance of workforce, families, and other unpaid carers. Now, a third action area, here on the right, is warranting the quality of long-term care with the provision of person-centered and integrated care through the establishment of minimum standards and accreditations for care providers. And based on my current work in the Netherlands, I would like to add that the supervision of care can play also an important role in this respect. Now, evidently, to establish a long-term care system will take time, including time for the research to inform the actions to be taken. In the meantime, it might be good to develop support services that are limited in terms of costs, but that can have far-reaching impact for people with dementia and their carers. Research mostly carried out in the global north, but also in the global south, show that there are several effective and promising ways to support and supplement family carers, including a range of psychoeducational and psychosocial interventions for carers, and what you see increasingly also for carers and people with dementia together. So you have these intervention programs focusing on the couples, and also including respite care, so that caregivers can have a break. Now, these interventions are all part of WHO Global Action Plan on Dementia, so there are recommendations in this plan to develop these type of interventions. And it's also accompanied by targets. And one of these targets is to have 75% of the countries to provide support and training programs for carers and families for people with dementia by 2025. And remember, this is also a plan that is approved, adopted by the Netherlands and South Africa. So to help countries, and may I have the next one? To foster caregiver support, the WHO has developed a training program for family carers named iSupport in collaboration with many experts around the world, a project that I've led. And iSupport is a generic program. Self-evidently, this program needs local adaptation. You cannot copy-paste, and I cannot stress that enough, you cannot copy-paste an intervention. It always needs adaptation to a local context. To illustrate, one of the countries that implemented this intervention has been India. And first findings in India show that the internet program seems to have a beneficial impact on some of the outcomes that we measured. But however, many people who signed up for the study hardly used iSupport. And we think because they couldn't navigate the internet program themselves. I mean, the researchers in India thought that they would, based on the spread of all the technology and the phones that people in India have. But actually they did not. And they needed the help of their children. So this is also something to take into account. How does that work and how do you need to implement then? And sometimes you only find these outcomes when you do the research and see what happens. So maybe using the hard copy version, we have now also a hard copy version of iSupport, in India might have been better, therefore. It also comes with an implementation and adaptation guide, iSupport. It can be used as a self-help tool, but also as a resource for professional or volunteers who support family or other unpaid carers. Next slide, please. On this slide, you see an overview of the lessons, and the content of iSupport is based on Kitwood's groundbreaking model, in which the personhood of someone with dementia is central, and in which care is essential, thought of through an interaction. So I come to my final remarks. As illustrated in this lecture, long-term care is a complex field. To develop and improve long-term care systems worldwide, there are many areas for which evidence is needed. The evidence is crucial to inform policymakers and other stakeholders, such as faith-based organizations, professional organizations, insurance companies, and the private sector to take the right actions. The extensive research agenda shows a wide range of opportunities for Optentia to foster the field of long-term care in Africa in general and South Africa in particular, and the importance of the contributions of different disciplines and multidisciplinary research. The extensive research agenda also clarifies that we need researchers trained in different disciplines, such as gerontology, geriatrics, public health, health policy, economics, anthropology, and cultural studies, to understand the scope of the challenges in the field of long-term care and bridge the gaps between different disciplines. And I look forward to collaborating with you, Jacco Hofman, and other colleagues, Vera, at Optentia in the coming years to build a team of researchers specialized in long-term care. And I'm wondering if you already showed the next one or not. A team of long-term care Springboks. Thank you for your attention.